In any patient day, one always thinks of Mark Haake because Mark is a scientist and a patient advocate. It's difficult to separate your passion from your science, but it's necessary. Mark does a superb job of caring, of feeling, of sharing, and loving the patients in need. But it does a superb job of his science. And his science is for the patient. And his science is good science. So Mark, you're the first speaker, well deserved. And Mark's going to talk about his most recent research and understandings of CCSVI.
Well, it's a great pleasure for me to be here. Sal, thank you for the invitation to speak to everyone today. You know, I'm being a scientist and not a neurologist or a physician. I'm afraid I'm going to stay on that bent today and try to present to you some scientific advances that have taken place since last year's New York meeting. And hopefully some of this data will be convincing enough for the neurologists to realize that we are getting more and more quantitative data that will allow us to demonstrate that there are differences between the multiple sclerosis vascular system and that for normal people. As it says here, I have NIH grants that are related to things that I do in this study, and I'm also involved with a company called Magnetic Resonance Innovations. So what I want to talk to you about today is something that came from a discussion with David Hubbard last night, so I'm using these two words from him, data documentation and CCSVI. And so today I'd really like to have you walk away from this meeting with the understanding that it's really important for clear documentation of all steps throughout your understanding of what you have with MS and what's done by the neurologists, by any interventionalists, by the radiologists. So what are these steps? Well, diagnosis, of course, by a neurologist at first, then studies of motor, cognitive, neuropsychological studies to see how you compare to normal people. Baseline MR imaging, which is going to be my focus for today. Angiographic evaluation, perhaps, if you're seen by an interventionalist. Possible treatment, and I don't say necessary treatment because an interventionalist may go in and not find something wrong. Post-angio MR imaging, sometime down the line, not necessarily the next day, maybe 3 months later, maybe a year later, especially as we're in this mode of trying to understand what did that treatment actually do? Can we monitor the changes in the flow? Can we monitor the changes in your brain that are taking place after you've had treatment? And then finally, the same neuropsychological tests that would take place afterwards. So why do I think it's important to do MR imaging? And again, by the end of this, I hope that I'm not the only one convinced that it's not just important, but I believe absolutely critical that MS patients have imaging before and after any treatment. We need to monitor the lesions and iron content and any other anatomical aspects that the neurologists think are important. So most of you will have had an MR scan already because the neurologist wants it. He wants to validate his thinking that you might have MS. He wants to get a diagnosis by the neuroradiologist that this might be what you have. We can monitor the arterial, venous, and the CSF flow during this MR procedure that you have. These are special sequences that I'll show you some example results of today that lets us tell you how fast the venous flow is, how fast the arterial flow is, how quickly the CSF goes up and down the spine during the cardiac cycle. You can create 3D vascular information, and this 3D information can be shown in a way that the interventional radiologist can review it with the radiologist and decide ahead of time how are they going to proceed with this particular case. Maybe many cases are fairly straightforward, but there are many complicated cases that if you have this data ahead of time, you can probably make a much wiser decision in how you're going to approach this. You can categorize, possibly by having all this MR data from thousands and thousands of patients, which type of MS patients have which type of situation from a vascular point of view. There may be many people who have a stenosis in the lower left jugular. There may be many people who have what we've been calling a truncular venous malformation, or let's just call it a congenital abnormality that relates to the sigmoid sinus on the right side, for example, coming to a stop and not connecting to the jugular at all. So this type of information is very important. So if we can categorize the different types of vascular situations, can we also demonstrate which of those groups actually get better after treatment? Maybe there's a certain classification, like this truncated sigmoid sinus, where if you get treated, you don't get better. In that case, if we can understand this, there's no point in getting treated. There's no point in perhaps going in and affecting a jugular vein that probably doesn't have a lot of flow in it, even if it's stenotic, because you can open it up and it may still never get flow in it. So we need to know the answer to this question and not just hope it's going to work. And of course, this serves as a baseline for you as a patient, because a year from now or 2 years from now or 3 years from now, if your neurologist wants to have another scan, he can compare what it was like before you had treatment versus what it's like at that time. Unfortunately, sometimes there are restenosis that take place. How does an interventionalist know if you restenosed if you don't have a baseline scan? How do you know what you looked like beforehand and the flow is like beforehand if you don't have preliminary data to back that up? So this is extremely important. So what can we see with MR imaging? Well, of course, you all know that they do anatomic imaging to look at the lesions. This is a method called FLAIR. And you can see here some examples of bright tissue, and that bright tissue is usually not bright in the periventricular white matter, and it's an indication that there's something abnormal going on in that part of the brain. And this is what the neurologists and neuroradiologists look for when they're trying to diagnose MS. We can also study iron content. Now, iron content is, again, just a biomarker related to what might be happening in people with MS. The image on the left-hand side is a normal age-matched control to the image on the right-hand side. And this is in the area of the midbrain. And this darker area is, well, it's not quite shining. Oh, there it is. Maybe. There we go. This area is called the substantia nigra. Here, there's almost no iron content for a 30-year-old. And here's a 30-year-old MS patient, and you can see significant iron deposition in the substantia nigra. This is not normal, and so it's possible to monitor this with MR as well. We don't know yet if you're treated, would some of this iron go away? Is this iron necessarily a bad thing? Does it cause other problems? We don't know that yet. There has been a lot of study in Parkinson's disease on the role of iron, and especially in this part of the brain. And so there is some understanding of this, but there's not yet really something that says, well, if you have that much iron, you're definitely going to have motor problems or something like this. But it is a biomarker that there's a problem. So let's get into the anatomy of the vessels. Not the function yet, but just vascular structure. Here you can see an individual who has a rather severe stenosis in the upper part of the left internal jugular. Now, I don't know if this particular individual has abnormal functioning valves or not, but this is a pretty severe constriction in the upper part. How the interventionist will treat it, I don't know. But this is the type of information that's immediately available. If you're then treated after having been ballooned, perhaps in this area, perhaps in the lower part, if what Dr. Zamboni says is correct, that sometimes an upper level stenosis is actually caused by an abnormal valve. The point is you can monitor this before and afterwards and find out, did that treatment have any difference or not? Now, this is an example of 4 different cases that I just wanted to go over briefly to show the interventionalists mainly, but also for you to be aware as patients that the vasculature is very complicated, and it's not always related to valves. You can have an example here where there is a severe narrowing. There may be a connection with the sigmoid sinus here. There may not. I don't have the resolution with MR to demonstrate that, except to show you that there's a problem here on the right side. In this particular individual, it looks like we have this problem with sigmoid sinuses that actually don't connect with the jugulars. What would you do in this case if there's no connection? One has to be very careful about this. In this individual, it looks like there's a stoppage of the vessel here, but actually this vessel continues. If we look at a later time point, we can see contrast enhancement in here, but actually there may be a membranous material here that is actually preventing the continual flow in a normal way. So this is a very useful piece of information because the odds are the interventionist will find something wrong right here. And then here's another example, almost the same as this, but here there is a clear stenosis and a narrowing and a thin strip. And this is very similar to some of the early data that Zamboni found and published, showing that if you ballooned this, that you were able to return the flow to normal under those circumstances. Oops, sorry about that. Let's try that again. There's a little delay here. In this particular case, I show you this because, again, if the interventionalists wanted to be able to view this 3D data prior to treatment, they would be able to get a good understanding of all the different veins here and what roles they play. Some people have large external veins that develop because they have stenosis of one of the jugulars. In this individual, you can see here and here that they have bilateral stenosis at the upper level, and these are very severe stenosis in this case. So how does the blood actually get out? It gets out through other vessels. It gets out through the externals, which become fairly large here. Well, you can see them on the outside. So the body develops alternate pathways, collateral pathways to deal with this. Those collateral pathways are different from person to person. Some people will get enlarged externals. Some people will get enlarged anterior jugulars, so in the front of the neck. Others will have the vertebral plexus take over from this, and in that case, let's see if I can go back and show you this previous example. Here you can see the vertebral plexus on the left-hand side here. You can see a significant enhancement of the vertebral plexus. These are the collateral pathways for that individual. There are other individuals that don't show that same enhancement of the vertebral plexus. They get carried out by other major vessels. So you can see the externals here are quite large compared to on this individual. Everyone has his own drainage pattern associated with the venous system. So what else can we do? We don't just look at structure here. We also want to look at the function. And this function may be, in the end, far more important than just the structural component, because you may have a narrowing of a vessel. As in carotid atherosclerosis, you might have a 60 or 70% stenosis of the carotid artery. But if the blood flow through that carotid is normal, and there's no indication that there's a danger for vulnerable plaque, you're not going to treat that. You're going to leave it alone. At least this is the more modern view. It's not just an issue of stenosis. So can we say the same thing in looking at the veins? If you have a slightly stenotic jugular, but you have absolutely normal flow through it, what will you gain by ballooning this? And I think we need to be asking the same type of careful technical question here related to this. So here what we do is we take a cut through the neck like this. So we get a cross-sectional cut, and we can look at every major vessel, both vein and artery, that is both feeding the blood to the brain and draining the blood from the brain. And what we do is we go in and we draw these regions that are shown by red circles and blue circles to draw the arteries and veins, and we measure the flow through each one of these. So this image in the middle is a representation. The bright represents the carotid arteries flowing toward the brain. The dark represents the venous blood flowing back towards the heart. And if we look at this bottom left image, this is a plot of the speed as a function of the cardiac cycle. So there's roughly we take a picture every 40 or 50 milliseconds, roughly a 20th of a second. And from each of these pictures, we measure the flow. So in the cardiac cycle for this individual, you can see that the flow basically goes to zero for a major part of the cardiac cycle. And this is just what Zamboni saw in many of his cases, that sometimes there would be reflux or basically no flow. So this individual is one of the worst cases I've seen. It's not just one of his vessels that goes to zero. All 4 of the major vessels on this individual go to zero, and that's not normal. So now that we have this 3D information, we can go and reformat this to look at each individual vessel in 3 dimensions. We can look at each individual lesion in 3 dimensions. We can carefully monitor these over time and see what happens pre and post treatment. And now I want to show you the example of this individual, the previous person. Here we can see the flow. And Sal, I don't know if you have a better pointer than this or if someone has a better pointer, but it would be useful to have this. In fact, I'm just going to walk up here, show you. This is the flow as a function of the cardiac cycle. And so this is the beginning of the cardiac cycle, the end of the cardiac cycle. And you find here that you get about 6 milliliters of flow at the end of that cardiac cycle. That's pretty good. That's for the right internal jugular vein. It turns out that the left isn't working at all for this individual. But the anterior jugular has taken over a little bit. That's that vessel that comes in the front. And it's carrying a little bit of the blood flow, so he's helping. And there's many other small vessels here that have taken over the load from that left internal jugular. But what we've seen in many MS cases is that one jugular does most of the work. Well, that might be a little bit of a dangerous situation, because you could imagine, under the wrong circumstances, if you ended up compressing that jugular, you don't have the ability to really get the blood flow out anymore. Most people with 2 jugulars, for me, for example, if I turn my head this way and I compress my right jugular, then I will see the blood flow increase on the other side because I have my vessels working properly. But if you have only one major vessel draining that blood, compressing it may not be a good thing. And over years and years and years, that problem may end up being part of the difficulty related to multiple sclerosis. That's just a hypothesis. Nobody's actually demonstrated this yet. But these are the types of abnormalities that we're seeing in multiple sclerosis patients. So here's a very different example. Again, you can see a lot of abnormalities on the venous side. I'll walk up there again. So here you can see abnormalities and narrowing. You can see narrowing here. There's narrowing here. But this individual doesn't have just a vascular problem. On the venous side, this individual also has tremendously abnormal arterial flow. It turns out that one of the vertebral arteries doesn't flow up, but flows down. And there is a missing vessel on the arterial side. This is a congenital abnormality, not just on the venous side, but on the arterial side. So by properly mapping this out, using the 3D MR techniques, mapping out the arterial and the venous flow, we can see this. So I'm going to go up here and just show you this in a second. This is a vertebral artery. This is a vertebral artery. This is a jugular vein. Right means flow toward the heart. You'll notice that one of the vertebral arteries actually flows back towards the heart. There is a secondary pathway on the arterial system for this individual that even further complicates their situation. So again, having complete flow information will help you understand the cardiovascular input-output associated with the MS patient. And the other thing you can notice on the upper right plot, you notice again there's only one line that clearly carries all the flow. You can see this. Right here. So this individual has only one vessel that carries most of the flow. So he's compromised on the arterial side and he's compromised on the venous side. So what can we do with all of this? Can we follow patients? Well, here's an individual. If you look at the left-hand image, you see a stenosis. This was done pre-treatment. In the middle image, it looks pretty good. This is done just post-treatment. So in this individual, it looks like the treatment worked. The patient did get a little bit better. On the right-hand side is many months later when the patient began to have symptoms return, and now you can see a demonstration that, in fact, the stenosis had returned. And so you can compare this data, pre-treatment, post-treatment, and validate why he might be having a return of symptoms. Now, one of the real questions in my mind these days, as I mentioned at the beginning, is how do we know who to treat? How do we know who's going to benefit from this? We don't yet. Hopefully this will happen with the studies that Sal was just alluding to, where many of the interventional groups are now getting these IRBs, or Institutional Review Board approvals, to go ahead and start collecting data and reporting on data. This is absolutely critical for you as a patient too, because you want the answers to all of these subtle questions, and maybe not so subtle questions. So this individual looks like they have a lot of nice, wide, functioning vessels. And it turns out that this individual does have pretty good blood flow. Let me show you that. Okay, so here you can see two of the major vessels carrying lots of blood flow. Here you have the left, here you have the right. They both carry about the equal amount of blood flow. All right, well, that's pretty good. And if you add up the total amount of blood flow, it's about normal for most people. So, would you treat this person? So, what if this person was treated? And what if it turns out this person now has a complete obstruction on one of his vessels? That's not a good thing. So one has to ask, why did you treat him in the first place? Did you think you saw something wrong when you were in there as an interventionalist? Did you think there might be something wrong with the valves? So I'm playing devil's advocate at this point. I would say, in order to draw these conclusions, we need to do things exactly like are being done with carotid atherosclerosis. We need quantitative data. We need quantitative flow data. If the flow is normal, why are you doing something? So I think we have to be very careful about this. So it's very upsetting to me if I find that someone has come back and had these measurements, has fairly normal flow, but after the treatment is worse off than they were before. So these are the types of questions that we need to be prepared to answer, and we need to have the quantitative data to do that. Now I want to show you something that is an indication that MS patients really do have abnormal flow in the jugulars. So there was a work by a fellow named Dupp in 2004. He's recognized out of Germany as being an expert in ultrasound, and he took a group of 50 normal people. And this group of 50 normals is shown in the blue bars here. And what this 72 means is that 72% of those 50 people had most of the blood flow carried by the jugulars. Okay, we all kind of grow up, knowing about that and talking about that the jugulars are very important. And so for most people, they are. However, in about 22% of people, only about between 1/3 and 2/3, so let's say roughly half of the blood flow out of the brain is carried by the jugulars. So that's normal too. Remember, we need to compare the MS population with normal population. And according to Dupp, only about 6% had the jugulars carry less than 1/3 of the blood flow. So what we did is we took a series of 200 MS cases, done at different sites, with both structural imaging and flow quantification. And we looked at those images that I showed you here and separated them out into two groups. One group that we couldn't find any structural abnormalities at all. And if we plotted the flow for those people with no structural abnormalities, amazingly, we get almost the same results as Dupp saw. We saw in those people that 70% of the people had normal blood flow in the internal jugular veins. And 30% of them had between 1/3 and 2/3 of the flow. So they just looked like Dupp's normal population. Now, what about the people that looked like they had stenosis? Well, you might think that if you have stenosis, of course you're going to have reduced blood flow in the jugulars, right? And so it may be no surprise to you that at one of the sites, where we now see in green here, only 44% of those MS patients actually show most of the blood carried by the jugulars. And 42% are now category 2, and 12% in category 3. At one of the other sites, maybe they had more severe cases in this case, we find only 28% of people fall in category 1, and 55% of that MS population sits in category 2. Clearly, totally different than the normal population. So there is something different going on in the vascular system for MS patients. So in conclusion, I think it's extremely important that we understand the hemodynamics and fluid dynamics of the brain. It may be that for some people, it's not just the flow out of the neck that's critical here. It may be that the whole vascular structure in the brain, for some people, you were born with that design that most of the blood's going to flow out one side. And in fact, normally, most of us do have an asymmetry between left and right. For MS patients, it may be more asymmetric than normal people. So it could be that opening up a vessel in one individual won't even help increase the flow because the brain wasn't designed to increase flow in that direction. So we need to study how the brain works from a flow point of view. In my opinion, patients should be imaged before and after treatment. And I think, as you saw from this quantitative flow example, that maybe flow quantification should be one of the criteria being considered by interventionalists before they make a decision on what to do. We should then create an international database so we have not just hundreds, but thousands and tens of thousands of data sets from which we can draw the right conclusions. And I think what Sal was mentioning to you here is a push in that direction so that we can try to get all of these major sites who are doing things to share their data. And finally, I think one of the things I haven't really focused too much on here, although I've hinted at it, is we need to do normals. If I don't have data for 1,000 normals, how can I say that the MS population is abnormal? How can I say that as Savadinov has pointed out, that maybe 22% of normal people also have narrowings of their vessels? I did a study a while back on 250 CT cases. I only found 8% of normal people had stenosis. So somewhere between 8 and 22%. But we don't have a comparison using exactly the same technology that I've shown you here that's been done on thousands and thousands of MS cases. We don't have that. Maybe doing the spouses of MS patients might be a good idea. Not kids, because they could have the same problem. Or maybe a friend or something like this. But we need to be doing as many normals as possible in the next year and not just forging ahead and doing more MS cases. We need to do at least 1,000 normals to be able to draw conclusions. So I like to call that the Millennium Project, and it's something that we're looking at trying to get funding for in order to do this. And one way that the MS population could help, you could send busloads of people to Detroit or busloads of people to New York who are normal. And although I say that jokingly, I'm really not joking. We absolutely have to do this in the next year. It's one of the most important parts of the research that's going on in this area. So you're welcome to go to the website ms-mri.com. We try to keep that updated. We also have the protocols listed there for any of the sites, including American Access, if they're interested in doing this at some of their sites. It's available to anybody. Anyone around the world is welcome to use this protocol. They don't have to deal with us directly. It's free, it's online, and they're welcome to use this. So in conclusion, I think we've come a long way. As Sal has indicated since last year, I think we have a long way to go. And let me stop there and see if there's any questions. Thank you.